At ASCO 2022, I presented 2 abstracts in the melanoma and skin cancer oral abstract session. The first were the results of the first analysis of distant metastasis-free survival in the KEYNOTE-716 trial of pembrolizumab versus placebo for resected stage 2B and 2C melanoma. The second abstract was the neoadjuvant trial, NeoTrio, looking at 3 different sequential or concurrent arms of BRAF-targeted therapy and anti-PD-1 therapy. At ASCO 2022, I presented the results of the KEYNOTE-716 data. This was the first analysis of the distant metastasis-free survival. We've already seen the recurrence-free survival data, which showed a significant improvement in terms of recurrence for resected stage 2B or stage 2C melanoma. So in this trial, patients with resected stage 2B or C melanoma were randomized to either pembrolizumab or placebo for 12 months of therapy. 976 patients were randomized, and at this first analysis, we saw a significant improvement in the distant metastasis-free survival with pembrolizumab compared with placebo. We also saw a much higher landmark 12-month and 24-month distant metastasis-free survival at those landmark rates. The hazard ratio was 0.64 with a p-value of 0.0029. We also saw the third analysis of the recurrence-free survival, and with this further follow-up of 27.9 months, we saw a sustained improvement in the relapse-free survival with a hazard ratio of 0.64. In terms of key subgroups, the benefit for distant metastasis-free survival and relapse-free survival favoured pembrolizumab in all key subgroups compared with placebo. And in terms of safety, there were no new safety signals from what we've seen with pembrolizumab in resected stage 3 or stage 4 melanoma. And in fact, there were no deaths due to therapy in this trial. So what does this data show us? This shows us that pembrolizumab anti-PD-1 therapy is very successful in preventing recurrence and preventing distant metastases in patients with resected stage 2B and 2C melanoma. At ASCO 2022, I presented the results from the neoadjuvant study, NeoTrio. The neoadjuvant platform provides a wonderful way to explore efficacy of drug therapies very quickly, cutting drug development from over 2 years down to 6 months, and NeoTrio is a great example of that. There were other neoadjuvant abstracts presented at ASCO as well. In NeoTrio, the question we were trying to answer is, can you leverage the fact that T cells are induced into the tumour with BRAF and MEK inhibitors and then add on anti-PD-1 therapy to get a nice durable response? In this trial, 60 patients were randomized to 3 different arms. All patients were BRAF mutant. In the first arm, patients were given triple therapy with dabrafenib, trametinib, and pembrolizumab for 6 weeks with stage 3 resectable melanoma. The second arm, patients were given 1 week of dabrafenib and trametinib in sequence and followed by PD-1 alone for 6 weeks. And in the third arm, patients were given PD-1 alone. The primary endpoint was the pathological response rate, and a key secondary endpoint was the relapse-free survival. So what did we see? The major pathological response rate in the triple therapy arm was 55%, with a complete pathological response rate of 50%. In the sequential arm of a little bit of dab-tram and then anti-PD-1, the major pathological response rate was 30%, and the complete pathological response rate 15%. For PD-1 alone, the major pathological response rate was 40% and the complete pathological response rate 30%. Importantly, those with a major pathological response in the PD-1 alone arm have not had any recurrence with over 20 months of follow-up, whereas we have seen a recurrence in each of the second 2 arms with 20 months of follow-up. So what we have learnt is that giving a little bit of dabrafenib and trametinib in sequence does not enhance the activity of immunotherapy. We have also learnt that targeted therapies do change the interpretation of the major pathological response rate. With immunotherapy, nearly all patients do well long-term in terms of relapse-free survival, but if you add targeted therapy, the major pathological response rate is not as easy to interpret. In terms of safety, we saw a high rate of adverse events in the triple therapy arm, such that 40% of patients had to stop the dabrafenib and trametinib in that first 6 weeks. In terms of next steps, this trial really does show that a little bit of BRAF and MEK inhibitor does not induce a nice immune response. We are now looking at all the tissue, because the other beauty of a neoadjuvant platform is the tissue collected at 6 weeks. So we are now looking at the biopsies and dissection specimens at 6 weeks to understand the biology as to why we are not seeing the induction of great responses of sequential therapy.